I'm Dr. Dan Rubin, and this is part 2 of a series of cryotherapy for the treatment of cancerous tumors. Dr. Barclay-White, in your practice, who is a candidate for breast cryotherapy specifically?
So there is a phase 2 trial going on right now, and I have been sticking fairly close to the trial. So small, newly diagnosed breast cancers, low grade, so slow growing, typically without metastatic disease to the nodes.
Okay. Is there an age restriction?
There actually is. On the trial, it's women 55 years of age and older.
Okay.
That being said, I've done several people off the trial. We've done faster growing tumors, we've done bigger tumors, and I've done younger women.
And so patients don't have to become part of the trial in order to be treated at your clinic?
No, they have the option. If we can get them on the trial, we want to do that because we want to accrue for the trial, but we don't have to do that.
And these are for people who may be looking for alternatives to surgery?
Almost always.
Okay.
Yes, they've usually seen a breast surgeon, seen a radiation oncologist, been told, they're probably candidates for lumpectomy, radiation, sometimes mastectomy. And these patients just don't want to go down that route. They want to explore other possibilities.
Is that what you typically see in your practice too, Dr. Stryker? People who are looking for some type of alternative?
Yes, absolutely. Or people who have been diagnosed with cancer and they have a recurrence.
Who's a candidate? Your practice is quite a bit different. Being an interventional radiologist, your work is done in a surgery center, I believe.
Correct.
Tell us about some of the cases or candidates that you've seen in your practice.
Oh gosh, I wish I saw the newly diagnosed breast cancers.
Yes.
But unfortunately, a lot of the patients, they undergo lumpectomy, radiation, mastectomy. So I see a lot of patients that have recurrence and even metastatic disease. And the cryoablation I do, but if they're bigger tumors or more advanced, I'll tend to do embolization first, which is cutting off the arterial blood supply to the tumor, allowing it to shrink some, and then do the cryoablation.
So then you have to ablate less tissue?
Yes.
Is that less traumatic to the body?
Yes, absolutely. Because the thing is with cryoablation, you're going to have a lot of dead tumor. And whenever you have dead tumor, they're going to release certain chemicals. And it can be very overwhelming for the body, for the immune system. The immune system, you want it to do its job, but it may become overactive. And so we don't really want those kind of side effects if we can help it.
Can, in your experience, can those tumors that have been ablated or while they're being ablated, can they also release cancer cells that then are termed circulating tumor cells?
Oh, absolutely.
Yes.
Which is why it's so important to have a baseline. And someone like yourself, who I have sent patients to encourage them. We need to know what their immune system's doing before we even start. That's the best case scenario.
That's a great role for naturopathic medicine too, is making sure that from a system-wide approach, their nutrients are up, that we are taking care of other ways that could contribute to a recurrence, specifically of breast cancer. We're looking at their body composition, we're making sure that their diet is straight, their immune system, that they're not ill or that their vitality is generally up, and that plays a role in the immune system and also helps protect them from circulating tumor cells.
Right.
Absolutely.
And I defer to you as well when patients will come to me for consultation. They'll say, do your work up with Dr. Rubin first, because it's kind of like, if we're in a post-war season, you don't have a whole lot of soldiers out there. But if you're during war, you have a lot more that are recruited. So if you've primed the immune system to have more soldiers that are available, it's just a win-win situation prior for them coming in for the cryotherapy treatment.
Yeah, and in another video that we're planning, which you can tune into our channel, we're going to talk about something called the abscopal effect, which is really an exciting subject, so I can't wait to get to that one. But it has been a pleasure to work alongside both of you and see the fascinating work that you're doing that it's not my scope of practice. It's not what I do. I take care more of the internal and physiology, but the localized treatment of malignant tumors is fascinating. It makes sense. It's less trauma. You can so control what you're delivering to the tumor. Dr. Barclay-White, tell us a little bit about the procedure. What would the patient experience be, and what can somebody expect once they arrive at your facility for treatment?
Well, I personally am doing them in the office under local anesthetic. We are doing small tumors, not necessarily newly diagnosed, because some patients are coming to me because they haven't been doing anything for years.
Meaning that they were diagnosed with breast cancer years prior.
Yes.
And it's slow growing.
And it's slow growing, and they've done, they've tried other things, and it's still growing, and now they've decided it's time to try and treat. So when they start researching the literature, they're very excited about the concept.
Especially, it sounds like these are people who either aren't ready to commit to surgery or just are opposed to surgery, and that they've been probably hoping something was going to come around, as they were self-medicating.
Many, many reasons. And a lot of them have been followed by other physicians and done different things, and those things have failed, and they're now looking for something definitive. So my ideal is a small, slow-growing tumor without any evidence of lymph node involvement. And we're not insisting on sampling that node. So typically those patients would be lumpectomy and radiation candidates, and they would sample the so-called sentinel node at the time.
Sure.
We're actually not insisting on that. If these are low-grade, slow-growing tumors, we're not insisting on that. And a lot of patients don't want that done. Yeah. They don't want anything done, so this is an alternative.
The patient experience, since you said it was local anesthesia, my guess is not too traumatic. Can patients generally drive home that day?
Oh, absolutely. We actually don't insist on any sedation at all. A couple of patients have wanted to do that. Most of my patients are awake and looking at the screen as we're doing it. Okay. It's really very similar to having an ultrasound-guided needle biopsy, which they've already been through.
They get to your facility, I'm sorry, and yes. Then what happens?
So we take them into their ultrasound room, often where they've had the biopsy, so they're familiar with the setup. We localize the tumor under ultrasound guidance. We put local anesthetic into the skin and over the top of the lesion. Luckily, the breast doesn't have a lot of feeling, actually, so usually anesthesia is complete, with a very similar anesthetic to what we would give for a needle biopsy. And then we introduce the probe under ultrasound guidance through the center of the lesion, and we create an ice ball. So there are 2 freezes, depending on the size of the tumor, with a thaw cycle in between. And basically, we put a steri-strip on the skin, and they walk out of there an hour later.
So an hour later, so from the time they get there to the time they drive home is about an hour.
It's about an hour.
Relatively not uncomfortable.
No. In fact, very few patients. I tell patients if they need to, they can take extra strength Tylenol for pain. Most of them call me the next morning, or I call them, and they say they haven't had to even do that. Wow. So they leave with a big frozen ice ball, which, is what we want, obviously, and they're pain-free. Great stories about them going off to Costco and out to lunch and to the movies. They all delight in telling me that. So, yeah.
Well, that's quite a different experience than what you see post-surgery.
Oh, yes.
Absolutely. Well, Dr. Stryker, given that you're an interventional radiologist, your treatments for patients are done inside of a surgicenter.
Correct.
What would a typical patient scenario be in your practice?
Well, it's a little bit different than Dr. Barclay-White's. I certainly wish I could see a lot of those that are newly diagnosed, but yeah. I get a lot of patients who have either, like you said before, either they've been diagnosed with a cancer and they want to do things on their own, and then things evolve, or I see patients that have had surgery, they've had radiation, they get a recurrence, and that other scenario isn't working anymore. So I see a lot of bigger cancers, more involved with the lymph nodes. They can even have secondary where it's gone to other organs. And
you can cryoablate secondary lesions in other organs.
Yes, absolutely. So the scenario is a little bit different than in office, but and we have nurse anesthetists that come in. They're wonderful. They're compassionate. They have a protocol where we give them either 1,000 milligrams of Tylenol. We'll sometimes give them some oxycodone, and then we use MAC, which you're not intubated, but you're maintaining the airway. So they're because these lesions are more extensive, and I'm looking at the lymph nodes and whatnot. So do the dual freeze of the lesions. If they're multiple, then I've got to go after multiple, and I go after the lymph nodes as well.
So a woman with breast cancer, whether it's primary or recurrent, could actually have lymph nodes that are positive, and those are ablatable in your practice.
Absolutely.
Or what about somebody with a lymph node maybe behind the breastbone?
No.
Okay, that would be interesting. Okay. So a lot of people may be looking at their pathology report or their mammography or their ultrasound and trying to figure out if they're a candidate, or they might be afraid to talk to their surgeon, especially if they're not local to San Diego or Arizona. So what happens? I mean, usually it's just great if people just pick up the phone and call your offices, but what happens if somebody, say, is not a candidate for treatment at your facility?
So in most ways, they can be candidates. Mm-hmm. So I am restricting myself to a sort of smaller, newly diagnosed, certain age restrictions.
And you guys have collaborated on cases too, haven't you?
Oh, absolutely. I've sent you, actually, I think now 3 cases that I wasn't comfortable doing as an in-office procedure with local anesthetic because they were more extensive.
I have to say, I'm excited. I'm so jazzed about cryotherapy. Look, I'm a naturopathic doctor, right? So it's so naturopathic because you're talking about the use of a temperature, the application of coldness, and an effort to stimulate the immune system. It's very naturopathic. It's obviously delivered in a way that I can't perform in our clinic, but thank you for collaborating, and thank you for what you're doing for patients in general, because this is a technique, and you're pioneering it too.
Well, I definitely feel that I personally am pioneering in this area, but it's so great in Scottsdale, but actually in the Valley.
In the Valley?
Yeah. They were doing them down at the University of Tucson, but they're not even doing that anymore.
Is it the University of Arizona?
Yes, the university.
So they're not doing it there anymore?
No, they're doing fibroadenomas, but
which is a non-malignant condition.
Right.
Well, and you flew over to watch me do one of the cases that you referred to me.
Right.
And I was showing her that she can do this.
Yeah, well, that's what she says, but I definitely would not be comfortable doing them under local anesthetic in the office.
Oh,
I mean,
no.
those more extensive cases need the OR, and they need anesthesia.
What are some of the surgeons' reactions to the use of cryotherapy? Are they generally accepting?
Well, I'm in a surgery center with a lot of different surgeons, so they are, because they're watching them choose routine treatments that we've done for the past 20 years, and they've seen some harsh side effects, and they're really excited because they see the very complicated cases that I receive, and I perform those treatments on those patients and see the outcomes. Even though they're very complicated, the outcomes are still good, and they're starting to refer family members now.
So has that been your experience in the Valley here too?
Oh, absolutely. And the patients, actually my greatest supporters are the patients I've treated. And they are now telling friends and family.
They're thankful, and they see the outcome and what they didn't have to go through.
And I think we had one patient come from, where was she from? Wyoming, and we've had 3 since that time because she's gone back and told her friends about it.
We should also be clear, we're not against surgery. We're absolutely not saying this.
No.
It's just that there's some people who are candidates for that. The surgeons are accepting of this, and want to be very clear that we're not anti-surgery.
Well, and the thing that I want to interject is that unfortunately I see a lot of patients that have recurrence, and I try to explain to them, if you get a positive margin after surgery, it doesn't mean the surgeon didn't do a good job. We can't see necessarily cancer cells that may be straggling around. So I re-inform them that the surgeon didn't do a bad job. It's just sometimes we don't know. But unfortunately, what I see is a lot of recurrence. So I'm treating these patients that then become very aggressive, because I always tell
the patient becomes aggressive.
No, the cancers become very aggressive, and especially after they've been treated.
Okay, with surgery
or even radiation. So I see it at the surgical site or at the radiation site. And
so these people who, some people are candidates for cryo even after surgery or after
absolutely. It's a little trickier with radiation because you're looking for that hydrolysis, and when they receive radiation treatment, that's drying out the tissue. So the tissue is more fibrotic. It's harder to get through, but you can get through it.
Okay.
Because my goal, and I tell patients, especially these larger lesions, and you either doing the embolization, cutting off the arterial blood supply, and then following up with cryoablation. They've got a big scar. It's a scar. It doesn't melt. It's going to be there forever. And I'll a lot of times refer them to a surgeon to have a lumpectomy, because I said, I've set you up for the best scenario because your immune system, you've got a dead tissue, it's your own personalized vaccine, And
it is your own personalized
it's your own
vaccine.
personalized vaccine, yes.
Produced specifically for you, by you.
Absolutely.
Inside your body.
Inside
Wonderful.
your body.
I have one question about margins. Margins are a big deal when it comes to surgery or anything, and margins mean after the surgeon removes the tumor or after the cryotherapy is done, is there cancer cells at the border, basically?
Correct.
In general, Dr. Barclay-White, is it your experience that you can perform cryotherapy and achieve a bigger margin than you can with surgery? With surgery,
Yes.
you can cut out so much tissue.
Yes, in fact, I'm aware of surgeons that are actually doing cryotherapy on the OR table and then creating the ice ball, which is now concentric around the tumor, and then cutting out the tumor. That's how they started, doing it, because obviously they wanted to see what was left, etc. But they actually continued using cryo in the OR under ultrasound guidance because they knew they got a nice concentric freeze around it, which
So
is
it's a nice
very
border
positive.
instead of a choppy sort of border.
Yeah.
But I have to interject.
Yeah.
The one thing that concerns me is that I always tell patients, if you're going to get surgery, wait about 30 to 60 days.
Yes.
Because I want that immune system doing what it was supposed to be doing in the first place.
No, cryotherapy is not new. It's newly on people's radar. It's searchable. People are starting to hear about it more. But as we've discussed before, dermatologists have been using cryotherapy for freezing or burning, so to speak, skin lesions.
For years,
Right,
very
for
successfully.
years.
That's
Absolutely.
right.
So who isn't a candidate for cryotherapy?
Everybody's a candidate for cryotherapy. In my particular office, I don't do anything above the collarbone.
You mean from here up?
Correct.
Why?
There's vital structures that you're getting close to that you know, like arteries, the carotid artery. You don't want to stroke a patient out, those kind of things. So, but any other part of the body, absolutely, below the collarbone, clavicle. I've even done tumors that are close to the bowel, and that's the beauty with using the type of gas I use is argon gas, because I can manipulate the gas. I can start at 12%, 25%, and it's slow. The ice ball is forming slowly. So it's not going near a vital structure. Okay. And then even if you went near an artery, the artery is pulsing and it's hot. So it's kind of like
That's fascinating.
You're going near an artery which is hot and warm. What happens to the ice? It starts to melt away. So
such a skill.
Which is why we can do tumors close to the chest wall, because the muscle's got great blood flow and it's warm, so we don't have to worry about freezing muscle.
The chest wall sometimes can become a problem, or the skin too, right?
The skin is, for us, the biggest problem.
Okay.
However, there are tricks in the trade
There are tricks, exactly.
What's a trick? And it's not really a trick. This is a certain
It's
skill.
a tool. It's a tool that we use. So we can actually run warm saline and through the skin. So again, you've got that fight where the cold is coming, but it's then hitting the heat.
Wonderful.
Okay. You can put a ton of saline in, sterile saline, to divert the ice ball from coming to the skin surface.
So you can really approach a certain margin and freeze it to the extent it needs to be freezed without damaging a structure that may be semi-critical or critical that's nearby. Using
Absolutely.
That tool.
Correct. But the other thing I tell patients, if you do have skin involvement with cancer, I'm not about cosmetic result. I'm about killing your cancer.
Yep. And I think
I've set it up where I will send them to a wound specialist.
We've had experience with our patients.
Exactly.
Yes.
But they have a great outcome, and
they
the
do.
goal is cancer. We're killing cancer with this.
And if people are sort of preloaded, or they understand that they're explained that, they're willing to utilize that tool and then know that they're going to be going through a wound healing period. That's where a lot of what we do as naturopathic oncologists come on board, is utilizing those nutrients and the techniques and the supplements and just the different physiotherapies that we have in our clinic to be able to help those people.
Well, and I have to thank you, because it's people like you and your colleagues across the country. I tell patients when they come in to see me, if you think I'm the end all be all, run, because I'm killing the cancer that I can see. But you may have some stragglers, even circulating tumor cells, that they need to see you to go after those circulating tumor cells so that they don't land someplace that we don't want them to land.
Well, I think if anybody is wondering if they're a candidate wherever they are in the country, they should visit your websites. Your website is what?
drstrykermd.com. That's drstrykermd.com.
Got it. Or your website?
And my website
Your breast
is
cryo
breastcryo.com or azbreastnet.com.
And ours is listenandcare.com.